شو ماكو تعال يحكي لا يوجد صوت يمكن عندي مشكلة.
Okay, tell me when you are ready. Okay. مساء الخير أخواتي وأخواني زميلاتي وزملائي وأهلا وسهلا بكم في هذا الاجتماع العلمي للجمعية الطبية العراقية الموحدة في المملكة المتحدة وأيرلندا والذي سيكون عن موضوع updates in maternal medicine. أود أولا أشكركم لمشاركتكم إن في هذه الأمسية، وأتمنى تكون يعني أمسية مفيدة لكم جميعا. وأحب أن أشكر أيضا جزيل الشكر الأخوات والأخوة المتحدثين الأساتذة، كل من الدكتور محمد عزيز، الدكتورة تغريد الحيدري، الدكتورة ندى صابر، والدكتورة تغريد حاتم، والدكتور عدي علي. Please, we'll send you a link to register yourself so we can, there's a feedback form you have to fill at the end of the presentations. And also, if you put your name as you want it to be in your certificate, and most important is your email. Please, we are sending the certificate and some of the emails coming back to us because there's a wrong email. So please check if there's any letter or any figure or number in the email. Make sure it is all right. And we appreciate your feedback. This will help us and will improve our service and our conferences for the future. Please, make sure that apart from the speaker, that you put your mics on mute. And if you have any question, please, if you write the question on the chat side of the page, what I do is I'm going to collect the questions, and then after we finish all the presentations, then I'll ask the questions to the speakers. I would like first to invite Dr. Muhammad Aziz to talk about headache in pregnancy. Muhammad is a consultant obstetrician and gynecologist at Ealing and Northwick Park Hospitals in London. He's a trainer and examiner with the Royal College of Obs and Gynae, and he's trainer and examiner at the BACCP, and he's trainer examiner at the Imperial College London, and also he's the chair of the ILG, which is the Iraqi liaison group with the Royal College of Obs and Gynae. Dr. Aziz will present to us his talk about headache in pregnancy. Dr. Aziz, the mic is yours now. Thank you.
Thank you so much, Rafid. Many thanks. I would like to thank the United Iraqi Medical Association, UK and Ireland, and many thanks to my colleagues who actually within a short period of time, they managed to produce or prepare presentations for today's meeting. I will talk about headache in pregnancy. Now, it's a very common problem, and it is outside and during pregnancy. Today's speak will show the etiology and types of headaches, management, and importantly, red flags, which are the symptoms and signs that indicate a headache that is not benign. In addition to some conditions that present with headaches, including preeclampsia, post-epidural headache, cerebral venous thrombosis, idiopathic intracranial hypertension, and also talk about the imaging in pregnancy. So headache is common, and it's common during the reproductive life. Most headaches in pregnancy are benign. For example, migraine or tension headache. However, the pregnant woman is at risk of life-threatening secondary headaches, like impending eclampsia or CVT. Failure to consider and recognize the potential devastating conditions lead to significant morbidity and mortality. Neurological conditions are the third most common cause of maternal death, according to the last Embrace report. The types of headaches classified into primary, in which there is no pathological reason behind it, which is migraine and tension headache, and secondary, which is more sinister cause of headache, including hypertension and preeclampsia, subarachnoid hemorrhage, drug-related, post-dural tap, meningitis, cerebral venous thrombosis, other conditions including anemia, caffeine withdrawal, idiopathic intracranial hypertension, stroke, and pituitary tumors. How to assess headache in pregnancy? So basically, we start as usual with history and examination. We have to have a full neurological examination, which allows us to find the correct cause of headache. A severe type or a typical type of headache may, after this clinical assessment, need to be discussed with the neurologist and urgent imaging considered. Now, the history, it's important to identify the presence or absence of red flags. Duration of headache, location, frequency, and severity are important. Family history, some headaches run family, including migraine and tension headache and associated symptoms. It's very important to ask the patient what they believe to be the cause of headache, because a patient with migraine, if she feels headache, she can tell you this is different from my migraine, or this is different from the headache which I usually have outside pregnancy. Now, what are the red flags? These are very important signs and symptoms. If present, we have to consider further investigations and assessments. This is adopted from the Scottish Intercollegiate Guidelines Network. The first one is thunderclap, which is a headache that progresses very rapidly to a peak intensity, so seconds to less than 5 minutes. Example of that is subarachnoid hemorrhage. Focal neurological symptoms, so a limb weakness or aura, which is less than 5 minutes or more than 1 hour. Non-focal neurological symptoms like cognitive disturbances, which is usually seen in central venous thrombosis, change in headache frequency, characteristic and associated symptoms, and abnormal examinations. Headache that's awakening the patient is associated with migraine and raised intracranial pressure. Headache precipitated by physical exertion or Valsalva maneuver, you have to consider subarachnoid hemorrhage or raised intracranial pressure. Patient with risk factor for cerebral venous thrombosis, jaw claudication, and visual disturbances. This is usually for age group that's outside the pregnancy, unlikely to happen in your pregnancy. It indicates giant cell arthritis. Fever, we may have to consider meningitis. Neck stiffness, again, it is a sign of meningeal irritation. And if there is any new onset of headache in patients with HIV or tumors, we have to consider metastasis. Now, examination. As obstetricians, we are familiar with neurological examination, usually the reflexes and tone and clonus. We have to add to that is fundoscopy, looking for papilledema, which is an indication of increased intracranial pressure. Cranial nerve assessment, the pupil reaction to light, which is the optic nerve. Eye movement, it will check the sixth nerve and third nerve palsy. Pupillary dilatation, indicate aneurysm of posterior communicating artery. Speech and swallowing, this will assess the cranial nerves, 9 and 11, 12. Tone and power reflexes are very important. If there is any asymmetry or reduce or increase in these, may indicate upper motor neuron lesion. And in addition to the plantar response, which is upward extension, is seen in upper motor neuron lesion. Now, we should not forget the preeclampsia. Blood pressure and proteinuria, in addition to clonus test, should be assessed in any case of headache. Now, I'll start with migraine. It's a very important subject because it is common. And also it is benign. So basically in the UK, there are about 109,000 migraine attacks each day. The condition is more common in women with high prevalence during the childbearing age. So usually within pregnancy, it be common. And pregnancy itself, it leads to reduction in the frequency and severity of attacks of migraine, and sometimes without aura. Migraine is classically unilateral. It's pulsating, build up over minutes to hours. It's moderate to severe intensity associated with nausea, vomiting, sensitivity to light, sensitivity to sound, and sometimes disabling, aggravated by routine physical activity. Migraine is classified according to the presence or absence of aura. Pregnancy can alter migraine aura and trigger attacks of aura without headaches as a result of high plasma concentration of estrogen. A woman may present with aura for the first time during pregnancy, which lead to concern regarding the diagnosis and the presence of intracranial disease. The symptoms evolve for more than 5 minutes and resolve within 60 minutes. This is for the aura, and it's completely reversible. Neurological consultation by neurologists can be assistance in recognition the typical pattern of migraine and aura. Women with experience of migraine have more than twofold increase in risk of preeclampsia. It's very important to keep an eye on pregnant women with migraine because of possibility of developing preeclampsia. Treatment. The first line of management is to avoidance of precipitating factors. So rest, rehydration, regular meals, and relaxation. Paracetamol and antiemetics may help also. And sometimes anti-migraine preparations may be needed. Triptanes, which is the 5-hydroxytryptane agonist or non-steroidal anti-inflammatory, may be used after discussion with the patient for the risk associated with these medications. Migraine was associated with 17-fold increased risk of stroke and 4-fold increased risk of acute myocardial infarction. So a pregnant woman should be aware about it. That's to say to improve her lifestyle to avoid an additional risk factor for these two conditions. Now, prophylaxis. If a woman experiencing 3 to 4 headaches a month, they may consider prophylactic treatment. The available one in pregnancy is a propranolol because it is safe. It is 10 to 40 milligram 3 times a day. Amitriptyline, again, in low dose is effective, 25 to 50 milligram at night. Now, preeclampsia, all of obstetricians are very familiar with preeclampsia. I put this slide to make some sort of differentiation between headache due to preeclampsia and other types of headache. So it's important that the headache happened in a woman who is pregnant or in the puerperia, and the preeclampsia or eclampsia has been diagnosed. And then evidence of causation demonstrated by at least of 2 of the following. Basically, the headache developed in actually relation to the onset of preeclampsia, and one of the following: the headache significantly worsened in the parallel with the worsening of the condition, or improved with the improvement of the condition. So if the preeclampsia improves and the headache is still there, we have to look for something else, especially complications of preeclampsia, including cerebral bleeding or subarachnoid bleeding. Headache has at least 2 of the following characteristics: it's bilateral location, it's pulsating equality, and aggravated by physical activity. And most important, there is no other diagnosis confirmed by this. this is the general view of the preeclampsia headache. I'll not go into details of preeclampsia treatment. I'll leave it to my colleague Uday. Now, another cause of headache, which is usually dealt by the anesthetist, is post-dural punctural headache. So women having the epidural and then complain of headache after that. The risk is about 0.5 to 2.5% of epidurals. If accidental dural puncture occur with the epidural needle, there is 70 to 80% chance of post-dural punctural headache. The headache usually is the fronto-occipital region and radiates to the neck. It is characterized to be worse and standing and typically develop 24 to 48 hours post-dural puncture. And conservative management usually includes hydration and simple analgesia. If untreated, it may take 7 to 10 days to resolve, but sometimes it's up to 6 weeks. And the definite treatment is epidural blood patches, which has 60-90% cure rate. Now, this is very important postpartum complications. It is several venous thrombosis. As we know, all pregnancy is a prothrombotic condition. There is increase in the risk of thrombosis due to the sluggish blood flow in the veins, and also a common occurrence of dehydration, infection, vomiting, in addition to risk of cesarean section or systematic infection. The greatest risk period is the third trimester and the first 4 weeks postpartum. The incidence is about 1 to 2,500 to 1 in 10,000. It's not common, but it's very serious condition. Thrombosis of the sagittal sinus with secondary extension into the cortical veins or primary thrombosis of one of the cortical veins are the most common. Now, what to do? The headache is usually the main symptoms, and some symptoms that appear after that. Headache is not specific, usually acute or subacute in onset, localized, continuous, and moderate to severe intensity. It's more often other clinical manifestation can appear after that. These include papilledema, focal deficit, cognitive disturbances, altered consciousness, and seizures. Now, psychosis has been reported with this condition, and development of symptoms may occur over hours or days or even weeks. The diagnosis, CT is important, but the sensitivity is low. Now we are using magnetic resonance venography, which is very highly sensitive to the diagnosis. And if any suspicion, we have to refer the patient to neurologist. Treatment, usually anticoagulation with low molecular weight heparin, and continue typically for 6 months. What we usually, if we have to monitor the patients, if there is any deterioration, we have to look for endovascular therapy. CVT associated with pregnancy and perperineum tend to have a better outcome than outside pregnancy. We usually arrange a follow-up MRV scan at 3 to 6 months after the diagnosis, and we have to investigate for other causes of increased thrombotic events, including thrombophilia. Now, idiopathic intracranial hypertension, again, it is a rare condition, but more prevalent in obese women of childbearing age. It may present for the first time during pregnancy, and sometimes pre-existing disease tend to worsen during pregnancy. The headache is generalized and non-throbbing, aggravated by coughing, straining, and associated with diplopia and visual loss in 30%. Again, with papilledema. Diagnosis required exclusion, and sometimes definite diagnosis by measuring the cerebrospinal pressure. It should be more than 20 centimeter water on lumbar puncture. Management include monitoring of visual field and visual acuity because the risk of optic nerve infarction. Women should be encouraged to limit weight gain, and the treatment we give is to prevent visual loss, including acetazolamide or repeated lumbar puncture. Now, important to look for the imaging of head in pregnancy, because many of the obstetricians would be very concerned if they refer patient to imaging. Now, the accepted background of cumulative dose of ionizing radiation during pregnancy is 50 milligray, which is 50 rad. Now, fetal exposure for CT is less than 0.005 milligray, which is less than 0.005 rad. MRI should be avoided in first trimester because of the hazard of hyperthermia. But MRI remains the preferable to any studies using ionizing radiation. So if we have to use any ionizing radiation, it's better to use the MRI. Contrast media should be avoided in pregnancy unless essential. If iodinated contrast used, we have to check the neonatal thyroid function after birth. And gadolinium-based contrast appear to be better and safe in pregnancy. Lactating women who receive iodinated contrast or gadolinium can continue breastfeeding without interruption. So in conclusion, many women experience headache during pregnancy and postpartum. Most of the time, it's benign headache, but doctors managing pregnancy and postpartum need to be aware of the symptoms, signs, and the appropriate response to the rare and more severe causes of headache. Pregnancy should not prevent us from referring to the imaging, and appropriate referral to neurologists should be part of the management of headache pregnancy. Thank you so much, and this is my references. Many thanks, Mr. Chair.
Thank you, Mohammed, for the interesting presentation. Thank you much indeed. As I said earlier, please, if you have any question, just if you write that in the chat side, I'll collect the questions and then we go through them at the end of the, after the last speaker finished their presentation. Now, it is our pleasure now to invite Dr. Tagreed Al-Haidari. Dr. Tagreed Al-Haidari, she's a consultant and professor in Obs and Gynae. She have MBCHB and CABOG. She works at Al-Kindi College of Medicine, University of Baghdad, and she works also at Al-Alwiya Maternity Teaching Hospital. It is Associate Dean for Scientific Affairs and Student Affairs and Postgraduate Studies. She is the Secretary General of the ISOG, and also she is in the Committee for Human Rights, FIGO, for Refugees, Violence Against Women. Dr. Al-Haidari will speak to us about obesity in pregnancy. Dr. Tagreed, the mic is yours now. Thank you.
Thank you, Dr. Rafid, for your nice introduction. Okay. Are my slides shown now?
Yes.
Yes. Okay. So my talk will be about obesity and obstetrical consequences in pregnancy. We'll have some talk about some statistics in regard to obesity in a pregnancy. We will have some notes about the pathobiology, and also we'll have some note about the trend of obesity, complications, and how to manage obese women during the first, second, and third trimester. If you have a look on the on this map, we can see in the Middle East, women tend to have higher body mass index than men. And you can see clearly for this is the map for Iraq, it's around 25.6, the mean body mass index for female, while it's 24.3 for male. And if we look to the map regarding the obesity epidemic in Iraq, the period between the first and the second map, it's around 40 years. And you can see that in 1976, the obesity incidence is around 10 to 15%, while 40 years later, the obesity tend to be 30 to 35% after 4 years, and you can after 40 years, and you can imagine how is the trend of obesity in our country and in the Middle East in general. And here is the prevalence of obesity in the reproductive age women, and you can see that it's tend to be more than 35%. So obesity, it tend to affect the pregnancy, tend to affect to carry many maternal complication, perinatal complication, offspring complication, and if we look to the obesity in the reproductive age women, it's 1/4 of the pregnancy complication are due to the overweight or obese mother. And maternal and perinatal complication and the risk are amplified with increasing severity of obesity. Here is the mechanism, how we get the effect of the obesity on the maternal and fetal consequences. In general, the adipose tissue, they are active endocrine organ, as we have an increment in the adipose tissue in obese women. And this adipose tissue will affect the metabolic and have dysregulatory mechanism on the metabolic and on the vascular organ, and also on the inflammatory pathways in many organs in the body. So in that way, it will affect the placental growth function and could be the mechanism in the production of preeclampsia. Meanwhile, obesity-related insulin resistance also has its roles on the placental growth function and could be implicated in the production of preeclampsia, and with its long-term obstetrical outcome. Meanwhile, it has its effect on the fetus also. This effect on the fetus and may be responsible for the long-term fetal and offspring outcome. That's because due to the permanent or transient changes in the metabolic programming, programming function, which that will affect the health and the outcome of the even of the adult life. That is by the epigenetic changes in the due to fetal exposure and increased level of glucose, insulin, lipid, inflammatory process during the development of the embryo, and could be the origin of the fetal origin. That's the hypothesis or the basis of the Barker hypothesis, that fetal origin of adult disease theory. So that can we see that obesity, it has a long-term consequence in regarding to obstetrical outcome and even on the offspring and the adult life due to the fetal origin of disease. Many studies have confirmed the correlation between the obesity, the severity of obesity, and maternal and fetal outcome. And that's one of the studies. It had been run by the ACOG at 2018, shown that women with body mass index more than 50, they are at a significantly increased risk for prenatal complications in comparison with obese women with lower body mass index. And the same is true to the other study run in Australia, shows that maternal super obesity and perinatal outcome in Australia, a national population-based course study, showed that super obesity in pregnancy in Australia is associated with increased rate of pregnancy and birth complication, and even with social disadvantage. So when we look to the body mass index in a pregnancy, it's really difficult to estimate that. There is no consensus on the body mass, on the proper body mass index during pregnancy, because most of the weight gain in a pregnancy is attributed to the gain of liquor, of the fetal weight and the blood. So most of the body mass estimation is depend on the pre-pregnancy body mass. So for that reason, the prevalence of obesity in reproductive age and the pregnant women is varies, and no exact estimation. There is wide variation between countries, depend on its circumstances and the country context, and it's range between 26 to 57%. And we can see that it's range from the underweight, normal weight, overweight, and obese women could be classified to class 1, 2, and 3 depend on how far it is more than 30 kg per meter body mass index. So what are the overall risk and what consequences of this obesity? This is a population-based study that had included over 740 pregnant women. Its composite severe maternal morbidity or mortality rate by body mass index. We can see that the higher the body mass index, the more risk of morbidity or mortality for the women. And class 3 obesity, it's causing around 203 per 1,000 women severe morbidity or mortality. This severe morbidity could be in any form, could be in a form of hemorrhage requiring transfusion, could be in a form of serious cardiac, respiratory, cardiovascular, hematological complication, could be in a form of thromboembolism, sepsis, shock, hepatic, renal failure, and even anesthetic complications and late diagnosis of uterine rupture. So what are the antepartum consequences of obesity? If we have a look on the early pregnancy loss, it is one of the consequences of obesity, has a modestly increase in case of obese women, and the higher the body mass index, the more risk. There are many explanations for that. Could be unfavorable hormonal environment, or it could be attributed to the chronic inflammatory process that we can see in polycystic ovary syndrome, which is got more worse during pregnancy and be responsible for the early pregnancy loss. In addition to any other theories that could be implicated as the cause for early pregnancy loss. The other important problem, as we all know, that medical problems are more common in obese women. One of them is diabetes, focal diabetes type 2 and gestational diabetes mellitus. Both of them are increasing and maybe due to the increasing in insulin resistance. And in addition to that, the pregnancy induced hypertension, whether it is gestational hypertension without proteinuria or eclampsia, both of them are increased in case of obesity, and also maybe attributed to insulin resistance, maybe attributed to the other cardiovascular effect of obesity, which contribute to the pregnancy-induced hypertension. Preterm labor also, it could be increased in obese women, and in most of the cases it's iatrogenic. It's induced preterm labor because of the complication, because of uncontrolled diabetes or hypertension in case of obese women. But still the mechanism for the spontaneous preterm labor is undetermined. Post-term pregnancy is also more common in obese women. This may be actually because of overestimation of gestational age. As we know that obese women, they tend to have oligo-ovulation, so they may have wrong calculation and maybe wrongly estimated a post-term. In addition to that, we have some sort of difficulties in diagnostic difficulties regarding the ultrasound, regarding the estimation of the fetal lie, the fetal presentations, and that will implicate it in reduction in detection of fetal anomalies. In that way, we need to manipulate the ultrasound procedures. Multifetal gestation also is more frequently, and especially dizygotic twin can increase in case of obese women, and this may be correlated to high FSH level, which sometimes has been seen in obese women, especially with the higher obesity than more than 30 kg body mass index. Obstetric sleep apnea, also they are more frequent in case of obese women, and they are contributing to increase the risk of preeclampsia and gestational diabetes mellitus in case of obese women. Carpal tunnel syndrome is also frequently seen, which is a common findings in obese and also in a pregnancy. It's even in a normal pregnant woman, it can be found. Here is a table that has been the result of a population-based screening study that have been published in the American Journal of Obs and Gynae, and you can see clearly how much the morbid obesity contribute to the poor obstetrical outcome, mainly in the form of operative vaginal delivery, of gestational hypertension, gestational diabetes, and here's the birth weight more than 400 gram and 4,000 gram with all its complications indication of an increasing rate of cesarean section and shoulder dystocia. What about the intrapartum complications? It will affect definitely the progress of labor, especially the first stage of labor will be affected by obesity and has modest impact. And that is why it's affect the progress of labor, maybe because of the fetal weight and also because of the maternal weight that could affect the progress. And but the second stage is usually not affected by the body mass index. It's mainly the first stage of labor. Regarding induction of labor, we have more induction of labor in case of obese women. Because of complication, as we say, they are more commonly, so we may induce labor because of hypertension, because of diabetes, and also it's tend to have more unsuccessful induction of labor or induction of labor that end with cesarean section, or also it's tend to have more prolonged induction of labor. For each, there is an 0.3 hours increment in the time of induction of labor for each 10 kilogram increment in body weight. Also, cesarean delivery is rather more common in obese women, as obesity is an independent risk factor for cesarean section. A trial of labor after cesarean section also can be affected, as we know that body mass index variable is indicated in the risk calculator for the success rate of a trial of labor after cesarean. Anesthetic problem is another issue that need to be considered in obese women, and failure of whether general or spinal anesthesia, sorry, is more common in obese women. Fetal macrosomia, another issue which is very important, that body weight of the fetus more than 400 grams tend to associate with increased rate of cesarean and shoulder dystocia. Postpartum complication even also increase. It's a more tendency to have venous thromboembolism, as obesity, as less mobilization, more incidence of cesarean. So all these may be implicated as a cause of venous thromboembolism. Infection also definitely is more. She needs to have prophylactic antibiotic. Postpartum depression have been seen in many studies. That's also increase in case of obese women. So what about the offspring? They also share the complication of obesity of their mother. So congenital anomalies, they are more common: neural tube defect, cardiac malformation, orofacial defect, limb reduction defect, and as the higher the body mass index, the more the risk of a neural tube and congenital heart disease. And it has been seen by many studies that even neural tube defect has nothing to do with if the woman have folic acid supplementation of the pregnancy. So that's more related to body mass index of the woman rather than to deficiency in folate. Asphyxia and death also is more common in such offspring. Risk of fetal death, birth asphyxia, perinatal death, all type of death, neonatal, infant death, all have been increased. And a meta-analysis of a cohort study found that even modest increase in maternal body mass index could increase adverse fetal outcome. Prematurity, as we said, it's more common, and mainly in it's iatrogenic, large for gestational age baby is more common with also its complication, and increased pre-pregnancy weight has a linear relationship with the birth weight. And the larger increment in body weight during pregnancy, the more probability of having a large for gestational age baby. The other issues is childhood obesity, cardiometabolic morbidity, also can be one of the consequences of maternal obesity. And as we said, because of the exposure in utero to insulin, to hyperinsulinemia, and this will may be implicated in later development of adult hyperinsulinemia, high lipid profile, in liver disease, and hypertension. Neurodevelopment abnormality also are more common in such offspring, and there's maladaptive programming of the fetal brain because of high adipose tissue. Also, asthma is more common in such offspring. So how to deal with such women? Pre-pregnancy preparation of obese women is very important to decrease and prevent complication. Preconception counseling, how to reduce weight, how evaluation need to be modified and changed to obese women, and even the care before pregnancy is very important. Pre-pregnancy weight loss is important. Many studies have shown that 10% reduction in body weight before pregnancy will reduce the risk of preeclampsia, gestational diabetes, indicated preterm labor, large for gestational age baby, macrosomia, stillbirth by 10%. And if the woman decreases her weight by 20 to 30% before pregnancy, she will have a reduction to the risk of shoulder dystocia and cesarean delivery. Bariatric surgery before pregnancy also may be very helpful in reduction of preeclampsia, gestational diabetes, large baby, and macrosomia. So what we need to do in the first trimester, as we said, we need to modify the antenatal care. Actually, in Iraq, unfortunately, still we are doing the same scheduled antenatal care for women regardless of their body mass index. So assessment of body mass index, blood pressure, yearly ultrasound is very important for accurate dating. Medication review if she is already on oral hypoglycemic agent, so it needs to be changed, or if she is already on treatment for weight reduction, that's need to be stopped during pregnancy. Diabetic screening is very important since she is at risk. Bariatric surgery maybe have already done before pregnancy. Exercise is important to be continued. Gestational weight gain to be modified according to the pre-pregnancy body weight. Fetal aneuploidy screening may be difficult, maybe need to be modified, maybe need to depend on other procedures as amniocentesis, alcoholic villus sampling, or to modify the ultrasound procedure, for example, doing transvaginal ultrasound or certain modification of in the examination to get a better view. Referral criteria need to be very clear. If she has any complication, cardiovascular, pulmonary, respiratory complication, in that case, need to be referred in a higher level services. Here's a chart that's the allowed weight gain during pregnancy and how it can be depend on the pre-pregnancy body mass index. The underweight normal weight, she can have increment in her body weight up to 16 kilogram per pregnancy. But if she is overweight, obese, she need to have some sort of restriction in weight gain during pregnancy. Second trimester, if the patient has several moderate risk factors and one of them is obesity, we need to start low-dose aspirin. In that case, to prevent subsequent preeclampsia. Fetal ultrasound survey is very important for fetal anomaly scan, as we mentioned that aneuploidy is increased, and 18 to 24 weeks is the usual time for doing the screening for fetal anomalies, and not to forget screening for gestational diabetes. To do that at 24, 28 weeks of gestation. Third trimester management, fetal growth assessment is very important. That will be by abdominal examination, palpation, which could be rather difficult and challenging in morbid obesity. Actually, in that case, we need to depend mainly on ultrasound, which need to be done every 4 weeks. Assessment of fetal well-being, that will be according to the obstetrical indication and not for obesity alone. And if we need to do external cephalic version for transverse or breech presentation, it is not a contraindication. It is actually welcomed in case of obese women to decrease the rate of cesarean section. So labor and delivery, timing and route of delivery, it is better to do a termination of pregnancy or induction of labor actually between 39 and 40 weeks, and it has been that not increase the incidence of cesarean section if you are doing induction at that time. Evaluation by anesthesiologist is very important. The route of delivery will be determined according to the obstetrical indication rather than the obesity. Equipment, instrument, and the labor and delivery unit need to be equipped with the sufficient instrument that's suitable for obese or morbidly obese women. And cesarean delivery, we need to take all the precaution in regarding to thromboprophylaxis, and we need to assess the woman according to the thrombosis risk and determine if she is in need for medication. And anesthetic consultation is very important to determine the best type of anesthesia. Antibiotic prophylaxis is mandatory in that case, and certain technical issues is very important during cesarean to decrease the risk of infection. Fetal monitoring, continuous monitoring of the fetal heart may be not appropriate in case of morbid obesity. In that case, placement of internal fetal scalp electrode will be useful if it's available. Actually, it's not available in our country. Postpartum care is important in such women. They are more liable for complication. So continuous pulse oximeter, respiratory physiotherapy, multimodal analgesia, postpartum immediate contraception is not contraindicated, and diabetic mellitus screening after puerperium also is mandatory. So what are the things to take home message for my presentation is obesity in pregnancy is best defined as pregnancy body mass index more than 30. Adipose tissue is an active endocrine organ. It can have dysregulatory effects. Compared with the pregnant women with body mass index less than 25, pregnancy among obese women are at increased risk of several adverse outcomes. What I'm concerned here mainly is modification to routine prenatal care is suggested in our country, and we need to stress about that because we are seeing more and more obese women during pregnancy. Here are my referencing, and thank you for your attention.
Thank you, Dr. Taghlid Al-Haidari. Very interesting subject really regarding obesity, and this is really it is affecting all the world really, but unfortunately it's affecting our countries and the Middle East even more in the last few years and over the last 1 or 2 decades. It is really worrying that the percent of obesity increased between 5–10% 40 years ago to 35 or 40% now, which is really worrying. Thanks a lot. We'll come back with some questions later. Thank you. Our next speaker is Dr. Taghlid Hatem. Taghlid Hatem, she will talk to us about sepsis in obstetrics. She's MBCHB, CAOBG. She's chair of the Iraqi Maternal Medicine Fellowship, and she's director of the Maternal Medicine in Baghdad Teaching Hospital. I don't know, Dr. Taghlid, are you with us now? Yeah, Noor, could you please unmute Dr. Taghlid?
Hello?
Yes, we can hear you, Dr. Taghlid. Taghlid, thank you.
مساء الخير دكتور.
مساء الخير، شكرا جزيلا.
السلام عليكم، جمعة مباركة جميعا. أتمنى يكون الجميع بصحة وعافية، وتمنياتي لكم جميعا ولكل الحضور بالصحة والسلامة بعيدا عن كورونا وأبناء كورونا وأحفاد كورونا.
شكرا جزيلا.
شكرا دكتور تغليد.
العافية إن شاء الله. إلى محاضرتك مع السبسس. الميكروفون it's yours now, دكتور تغليد.
السلايد ده يطلع دكتور العفو؟
Yeah, we can see your presentation and you can start now, Dr. Taghlid. Thank you.
إن شاء الله. الموضوع اللي راح أتحدث عنه شوي موضوع معقد، لكن إن شاء الله أكو فائدة بالمحاضرة. We talk about the maternal sepsis. The objective of the lecture, I will talk about the incidence and complication, definition of maternal sepsis, pathophysiology of the sepsis, risk factor for sepsis, causes of sepsis in pregnancy, prevention, how we diagnose and how we manage maternal sepsis. Incidence and complication. Sepsis is the 6th leading cause of maternal death in UK. It causes 8% of maternal mortality in the low and middle income country. It causes 8% risk of mortality in the high income country. It causes 5% of puerperal sepsis, and it causes about 10 to 25% of cases of stillbirth in the high income country, and 50% of IUD in the low income country. The WHO Global Maternal Sepsis Study Research Group, the GLOS, which ended in 2020, it was implicated in 52 countries, released the statement of that 70% of hospitalized women per 1,000 live birth had a maternal infection. 10% have maternal death in the low and middle income country. 10% per 1,000 live birth presented with severe maternal outcome. 5% of death in the high income country are due to sepsis. What is the sepsis fact? We must keep in mind, sepsis is one of the leading cause of a preventable maternal death. The 3 main substandard care factors commonly associated with maternal death is failure to recognize and respond to sick women, failure of antibiotic therapy, and failure to manage fluid balance appropriately. This is a WHO poster released to draw attention about the maternal sepsis in pregnancy during childbirth, 6 weeks postnatal and post-abortion. To understand the pathophysiology of sepsis, we have to review the physiological changes during a pregnancy that affect all the system of a pregnant mother. The pathophysiology of maternal sepsis is complex, and it needs the interaction of multiple biological pathways with both positive and negative feedback loops. When this interaction of pathway become uncontrolled, will lead to widespread tissue injury and organ dysfunction. The pathophysiology of septic shock, the interaction between the pumps, which is the pathogen associated molecular pattern on the bacteria, and the receptor will need the innate cell to trigger nitric oxide and cytokines with the massive vasodilatation and tissue injury will lead to DAMS release, the DAMS, which is a danger associated molecular pattern, which lead to direct cardiomyocyte death. The effect of a pregnancy physiology on a clinical presentation on the sepsis. On the left side, this is the physiological changes of a pregnancy. On the right side, this is the pathophysiology of sepsis. Both of them will lead to the accumulative effect, and that lead to cardiovascular impact with rapid hemodynamic collapse, and with susceptible to pulmonary edema, rapid decrease in oxygenation, adult respiratory distress syndrome, decreased ability to compensate for metabolic acidosis, can lead to acute renal injury, coagulation will be increased DIC, and end organ dysfunction. How we define sepsis? In general, sepsis is a life-threatening condition that arises when the body responds against infection will lead to tissue and organ damage. SIRS is the systemic inflammatory response syndrome. Sepsis is suspected or confirmed infection plus 2 or more of the SIRS criteria. Severe sepsis is sepsis with 1 or more organ dysfunction due to tissue hyperperfusion. Septic shock is severe sepsis plus persistent hypotension or new onset hypotension despite fluid resuscitation or requirement of vasopressor or lactic acid more than 4 millimole. What is the definition of maternal sepsis? It is a life-threatening condition defined as organ dysfunction released from infection during pregnancy, childbirth, post-abortion, or postpartum period. Septic shock, defined as sepsis associated with vasopressor requirement to keep the mean arterial blood pressure more than 65 millimeter mercury in the absence of hypovolemia, or a serum lactate more than 2 millimole, or the need to use inotropic agent. What is the maternal SIR criteria? It is a clinical response from non-specific insult, include two of the following: hyperthermia more than 38 centigrade, or hypothermia less than 36, tachycardia with pulse rate 110 beat per minute, increased respiration, white BC count more than 15,000 per cubic millimeter or less than 4,000, or the presence of more than 10% of immature neutrophil, altered mental status, or hyperglycemia with more than 140 in the absence of diabetes. This is a table or paragraph of the SUFA and the quick SUFA, which is released and proposed by the Australia Medical Maternity Center and New Zealand. What is the etiology of infection during pregnancy? In general, etiology of infection during pregnancy can be divided into direct, with infection in the genital tract, or indirect, when the infection is outside the genital tract. The most common cause of antenatal infection antepartum is septic abortion or chorioamnionitis, especially with the pre-prom, complicated pyelonephritis, appendicitis, cholecystitis, acute pancreatitis. Especially these cases are difficult to diagnose during pregnancy. Pneumonia caused by streptococcal pneumonia, TB, influenza, H1N1, and COVID-19. Postnatal infection, the most common postpartum infection is endometritis, which usually caused by mixed flora. Other postpartum infection include wound infection, pelvic abscess, gas gangrene, pyogenic sacroiliitis. We must not forget the COVID-19 pandemic, which continued to have significant impact on the care of pregnant women and postpartum period, and associated with a lot of maternal deaths. The last WHO has highlighted that pregnant women from a Black and other ethnic minority have more likely to be hospitalized with infection than white women. What is the risk factor for maternal sepsis? It can be divided into maternal condition, community condition, and delivery condition. What about the maternal condition? When the pregnant mother have impaired glucose tolerance, have invasive procedure, impaired immunity, pelvic infection, poor nutrition, primary obesity مثل ما قالت الدكتورة تغريد الحيدري, anemia, malaria, delivery condition, if there is postpartum hemorrhage, multiple vaginal examination, delivery under unhygienic condition, prolonged rupture of membrane, invasive procedure, cesarean delivery, and prolonged labor. The community-based condition, long distance from healthcare facility, delivery by untrained attendant, delay in seeking the treatment, low socioeconomic status, and lack of transportation. Again, this is a table to show the risk factor between the high-income country and low-income country. On the top, we can see in the high-income country, the rate of the cesarean section and emergency cesarean section are at the top of the list. In the low-income country, poverty and unhygienic birth condition is at the top of the list. What is the clinical feature and sign and symptom of maternal sepsis? This figure and the poster, to simplify and to be easy for the healthcare worker to see. Fever, poor oxygenation, decreased urinary output, hypotension, rapid pulse, rapid breathing, impaired consciousness. And the symptom, constant severe abdominal pain, uterine tenderness, chills, vaginal discharge, especially offensive, delayed uterine involution, vaginal bleeding, rash. This table is modified and put, and they are very useful in identification of sires during a pregnancy. How we prevent maternal sepsis. Prevention of maternal sepsis urgent need for multimodal prevention approach with the use of guideline, education and training, organizational changes, surveillance, and quality improvement. And this is post-release by the WHO to practice clean care for mother, diagnose early, and early treatment. This is again a poster released by the WHO about the how to draw attention about maternal sepsis. What investigation we need? Blood culture, collect and send prior to initiating antibiotic. Microbiology, we can take vaginal and endocervical culture, throat swab. Blood chemistry, we need to send for serum lactate, CBC, C-reactive protein, blood electrolytes, renal function test, liver function test, urine collection and urine analysis. Imaging, we need to chest x-ray, pelvic ultrasound, and even CT. What is the biomarker we can use in the treatment and assessing patient with maternal sepsis? We have the C-reactive protein and procalcitonin. Both of them can identify patient at early stage of sepsis and can differentiate sepsis from other non-infectious inflammatory pathology. It can predict the clinical severity or outcome. It can guide escalation or de-escalation of the treatment. White cell count and C-reactive protein are non-specific for inflammation versus infection, but procalcitonin appear to be more specific for bacterial infection. Other biomarker is the lactate. It is a good indicator of tissue hypoperfusion and hypoxia. A venous lactate more than 2 millimole should be promote critical care input, and a level of more than 4 millimole per liter initiating a central venous pressure and IUC admission. Elevated serum lactate is associated with poor outcome in maternal condition and with a mortality rate approaching 46%. Bundles of care. What the meaning of SSC bundle? It is a pregnancy-specific sepsis bundle. The main aim of this bundle is a rapid investigation and early treatment. The key element is a low index of suspicion to aid early recognition and perform essential investigation and monitor by the sepsis 6. What is the sepsis 6? It is a blood culture, it is a blood lactate, hourly urine output, oxygen, intravenous fluid, and antibiotic. If we follow this bundle, we can decrease the maternal mortality rate by 25%. And this tables and diagram, it is all about the sheet of assessment of maternal sepsis. What the clinical action we can use in treatment of maternal sepsis? Start with A, screening for sepsis. Screening includes sequential assessment of SIRs, C, sepsis and severe sepsis and septic shock. All obstetric patients are screened for sepsis during assessment by healthcare professional at any time of on admission to the labor room and changing of the shift, if there is changes in the patient status or concern of infection. Once sepsis is confirmed by the physician, the following interventions are done. Draw a lactate and CBC, start IV access, order a blood culture in 2 sets prior to antibiotic if possible, initiate a broad spectrum antibiotic and determine the source as early as possible. We can use imaging and manage dependently on the finding. If there is chorioamnionitis, delivery is promoted. If there is septic abortion, evacuation of the uterus. If there is abscess, we drainage the abscess. If there is acute cholecystitis, cholecystectomy. If there is appendicitis, surgical removal. And we use the less invasive approach if possible. What is the 1 hour treatment bundle? That's mean to start to take action within 1 hour of suspicion or diagnosis of sepsis. Within 1 hour, obtain a lactic level, order blood culture, start antibiotic, and treat hypotension with crystalloid solution. B, identification of severe abscess. After initiating the sepsis, and we diagnose the sepsis, and we draw blood culture and initiate hourly chart, then the team will look for acute organ dysfunction, which either lactate more than 2 millimole per liter, there is decrease in the systolic blood pressure less than 90, or there's a difference in the baseline blood pressure more than 40, if there is bilirubin more than 2 milligram, if there is new or increased oxygen requirement, if the urine output decrease less than 0.5 ml per kg per hour for more than 2 hours, if the platelet count decreases less than 1,000, if there is coagulopathy, if the iron are more than 1.5, or the PTT more than 60 seconds. Level C is identification of septic shock. If acute organ dysfunction and severe sepsis is identified, then fluid resuscitation with normal saline, rapid response team, lactate order 6 hourly, strict oxygenation. If persistent hypotension or new onset hypotension despite the bolus intravenous fluid or lactate more than 4, consider the patient as a septic shock, move to the ICU unit. This table or this paragraph will aid the health worker caring of pregnant mother with sepsis, how to differentiate between sepsis, severe sepsis, and alarm them where to transfer the patient to the ICU. This is the same chart. What is the indication for intensive care unit? If there is respiratory need, pulmonary edema or mechanical ventilation, or airway protection, if there is need for renal dialysis, if there is significantly decreased conscious level, if there is multi-organ failure or uncorrected acidosis, or there is a hypothermia, if the maternal hypotension still in even after fluid resuscitation, or the serum lactate is still elevated, or the need for imminent inotrope support. What is the intensive care management? Maternal admission to ICU for sepsis and septic shock are uncommon, and a number of ICU management strategies currently used include glycemic control. Intensivists aim to ensure level less than 180 milligram per deciliter, and this would unlikely to adversely affect the baby. Uncontrolled hyperglycemia would be a greater threat. Steroid use, the current RCOG guideline do not consider the steroid use for sepsis, but recommended with caution to promote lung fetal maturity. Oxygen should be administered to achieve oxygen saturation more than 95%, either in form of CRT or CPAP, or and currently if there is renal damage, they put the patient on ventilator with the continuous CRRT. Novel vasoactive medication, vasopressor, can be used for pregnant women admitted to ICU with septic shock. The first line treatment in general is noradrenaline, which is effective and safe. Catecholamine and dopamine can cause arrhythmia, and the addition of vasopressor can help to reduce catecholamine dose. Reversible myocardial depression has been associated with sepsis, and inotrope could be considered when cardiac output has been compromised. This is a new drug, levosimendan, which is a relatively novel inotropic agent with vasodilator property and anti-inflammatory and antioxidative, and has a potentially protective for sepsis-related tissue injury. Currently, there is lack of safety and efficacy to be used in the obstetric. Intravenous immunoglobulin, so frequently used in the outside obstetric population, intravenous immunoglobulin can be considered as an adjuvant to antibiotic, particularly during severe invasive staphylococcal and streptococcal sepsis. Extracorporeal membranous oxygenation, it is just like an artificial lung, I think. It is used in the respiratory viral type 4. يعني في تصورها مو كل المراكز موجود بها هذه. It is just like bypass the lungs. What about the antibiotic therapy? To choose the antibiotic, we need to know what is the offending microorganism, and this is the list of the most common microorganism causing the maternal sepsis. When choose the antibiotic will depend on source of the infection, local resistant, and hospital protocol. In general, antibiotic recommendation, if the source is unknown, at least one antibiotic for gram-negative and anaerobic coverage plus one for gram-positive coverage, 7 to 10 days duration, usually adequate. And this is an example of the antibiotic use in the maternal sepsis. What about termination of pregnancy? Termination of a pregnancy in maternal sepsis, individualized case by case. Overall goal, treat the mother. Resuscitating the mother will resuscitate the fetus. Delivery attempting can be increased the maternal and fetal risk mortality, assuming the source is not intrauterine. Improve functional intravascular volume. Establish and maintain an adequate airway. Determine the septic foci. Empiric antibiotic therapy. Know the most common pathogen. Thank you. ونقدم تحياتنا للجيش الأبيض العراقي خط السطح الأول، نتمنى لهم الصحة ونسأل الله الرحمة والغفران لكل من استشهدوا من ضمن الجيش الأبيض العراقي، ونسأل الله المغفرة والرحمة لكل الهيلث وركر بالعالم كله. شكرا دكتور رافد.
شكرا جزيلا دكتور تغريد، محاضرة ممتعة جدا ومفيدة جدا. يعني احنا هنا بالنسبة للسبسس يعني تعرفون هو يعني it is treatable but still we are missing it. يعني سنويا في بريطانيا تسجل حوالي 4 مليون حالة من السبسس، يعني ما أحكي عن ماتيرنتي، أحكي بصورة عامة في الأدلتس، والوفيات توصل إلى حوالي 50,000 حالة وفاة بسبب السبسس. والمشكلة أنه we are always missing it early when it is treatable. There is a curve, and if we can catch the case early, you can give the antibiotics at the time and the support at the time, you can save lives. We come to that later when we come to the question and answers. Thank you very much indeed again. And our speaker now is Dr. Nada. So let me just, Nada Saber. Nada Saber. So Dr. Taghlid, do you mind if you just
stop the sharing?
Stop the share, please. Yeah, thank you.
Yeah, thank you.
Okay. So our next speaker is Dr. Nada Saber. Dr. Nada will talk to us about management of epilepsy in pregnancy. Nada Saber, MBCHP, MMED, FRCOG. She's a consultant in maternal medicine, and she's the maternal medicine lead since 2017 at Bedford Royal Infirmary. And she is the Foundation Training Program Director since 2019. Dr. Nada, thank you very much indeed for joining us today. And the mic is yours now. Thank you.
Assalamu alaikum. Thank you everyone for the kind invitation. I chose to use this first slide to just give you a little bit more about, my background. So on your right-hand side is the front garden of my parents' house here in Baghdad. And the rest of the screen presents what I really care about mostly, which is women's health. Left top of the screen is us recognized to be providing good service in Bradford, and we aim to be outstanding. So we've got now a recent project on how to get to outstanding performance and outstanding maternity care. And right at the bottom is something that I would like you to try to get hold of, which is a verbal communication produced by the British Medical Journal on epilepsy and pregnancy. My talk is going to be based on the recent report on cases of death, maternal death during pregnancy. These cases are complicated with severe epilepsy or poorly diagnosed or poorly managed. And the aim of the talk is to provide women with complex medical needs, particularly in epilepsy, with a safe journey. I'm sorry, can you hear me?
Yes, we can ask all the, please, the speakers to be on mute, please. Only the speaker, please. Thank you.
So moving on, recent reports suggested that we are missing many cases of sudden unexpected death related to epilepsy in pregnancy. And there have been a couple of themes identified, and I'm sure you agree that it's not particularly specific to women in England that we see that fear of changing or using anti-epileptic medication in pregnancy. So particularly, there is a tendency of sometimes having that extreme concern about the potential of a small congenital problem. And with that information, women decide to just simply discontinue their treatment and end up with cluster seizures, prolonged hypoxia, and they may eventually actually lose the pregnancy and also affect the brain function long term. So the aim here is to maintain treatment to the lowest effective dose. So I'm going to try to touch on why uncontrolled seizures, why ineffective treatment, and why we're missing many cases leading to sudden unexpected death. So it's been noted that there is a statistically significant increase in maternal deaths from sudden unexpected death in pregnancy related to epilepsy since the production of recent publications, including, I will touch on one of the recent publications suggesting that routine assessment of anti-epileptic medication load or level in the blood is not beneficial during pregnancy. Moving on. So we'll talk about misinterpretation of risk. What possesses risk in pregnancy? Obviously, we're talking about a mother and a baby. What is more harmful? Is it to have more seizures or the potential teratogenicity as a result of consumption of these anti-epileptic medication? So let's talk about risk. So tonic-clonic seizure per se itself can lead to significant prolonged seizures resulting in significant fetal hypoxia and also long-term brain damage to the mother, and it is recognized as a high risk for sudden unexpected death. One of the other things that we tend to miss is nighttime seizures or unwitnessed seizures. Let me take you back to diagnosis of epilepsy. Unfortunately, there are a number of things that we can do to investigate, including having an EEG or an MRI, but these can be negative and the patient can still be diagnosed with epilepsy. we predominantly rely on witnessing the seizure and the explanation and the aura surrounding the seizure for the neurologist to be able to diagnose epilepsy. Many cases are missed because they are unwitnessed, and this is one of the risk factors for undertreated seizures leading to death. Focal seizures, for example, are normally considered less worrying and less likely to cause long-term damage. However, it really depends on where exactly the focal seizure and which part of the body and which part of the brain it is affecting. So some of my colleagues may be surprised to know that focal seizures themselves are higher risk of SUDEP. Moving on and talking about interpretation of evidence. The EMPIRE study is a double-blind randomized controlled trial which has looked into the pregnancy register in England and Ireland and looked at a few thousand women. Unfortunately, the conclusion was there is no evidence to suggest that regular, and I'll put 2 lines under regular, monitoring of serum anti-epileptic drugs, and that is a very generalized statement, levels in pregnancy improve seizure control or affects maternal or fetal outcome. I will come back to why we said regular monitoring and why we said all anti-epileptic drugs should not be included in this statement, because this is very non-specific. Looking at also other risk factors, if you look at the biases related to women who were whom their death was attributed to epilepsy in pregnancy, few of them had mental health issues, but few of them actually had social deprivation as a risk factor. And you and I know that many of the women we look after have all these risk factors, including physical health problems as in epilepsy. You are all aware that a poorly controlled epilepsy can result in multiple traumas. Many of the patients end up with multiple bruises, multiple bone cracks, soft tissue injury, need for hospitalization. That leads to indirect correlation with mental health problem related to chronic medical problem and also previous pregnancy. So what I'm trying to say here, pregnant patients with epilepsy are very, very high risk group. You can't rely on a generalist to look after them during pregnancy. It's a highly specialized area. Whenever you meet somebody with epilepsy, no matter how well controlled you think there might be, please escalate and refer to specialists. Okay, so if we talk about steps to reduce the likelihood of missing cases, we talk about women's journey, pre-pregnancy and during pregnancy. Part of it is to ensure that there is a recognized place or a recognized team to escalate their care to, how to communicate and how much information this team need to be aware of, and the ability of this team to meet the patient prior to pregnancy. We don't try to scare patients. We actually try to encourage them, and we try to support them by actually evidence-based advice suggesting that 2/3 of patients will actually sail through pregnancy and the pregnancy will not increase the seizure frequency. However, we're talking about 2/3, 1/3 will have an increased seizure risk and need much more. Talking about medication during pregnancy, in the pre-pregnancy counseling meeting, we talk about various anti-epileptic drugs. Obviously, we aim for monotherapy if possible, if that achieves seizure control. If not, you end up with more than one, and you need to talk about cumulative risk. And that enables the patient to make a decision whether to fall pregnant or not. At the same time, that gives the team and the patient the chance to better control their seizure prior to embarking into pregnancy. Dose-dependent teratogenicity and all that should be discussed. But remember, bioavailability of anti-epileptic medication during pregnancy is actually different compared to outside of pregnancy due to multiple factors, including excretion, so kidney function or glomerular filtration rate is about doubled during pregnancy. So the bioavailability drops quite significantly. Protein-bound anti-epileptic medication, that varies during pregnancy and that results in reduction in bioavailability. Some anti-epileptic medication are liver enzyme inducers, so it can affect vitamin D level. You also need to have a discussion at the pre-pregnancy meeting to check whether a sustained release product is preferred to a normal release or an immediate release. So for example, the best example here is Tegretol. The prolonged release is preferred during pregnancy. Reason why we prefer sustained release is teratogenicity is associated with fluctuation of anti-epileptic drug in the circulation rather than the dose. So it's not primarily the dose of the anti-epileptic medication rather than the increase and the decrease of the anti-epileptic medication that leads to increased risk of teratogenicity. And that's a very important point. Moving on, we talk about why we should encourage women to continue on the medication, and despite external advice, we share the fact that seizure themselves can harm baby more than the potential risk of teratogenicity. Obviously, it varies between different anti-epileptic medication. We try not to scare women, but you have to be very honest about the chances of sudden unexpected death. We also, as I mentioned earlier on, it's an opportunity for us to think of postponing pregnancy until seizure control is improved. Obviously, I don't do it as a maternal medicine specialist. I do it with, in combination with advice and support from our neurology colleagues, with also the nurse specialist who sits with us and sees patients regularly. Right, so if we talk about antenatal care and what needs to be discussed, we need to be very, very clear and specific, guiding our juniors if we're talking about teaching hospitals on what to expect to be documented in these patients' case notes. So, for example, I'll move on and then I'll get back to the advice. You need to be very clear about seizure frequency, seizure type, and also you need to have a seizure diary to enable you to know whether the treatment is suboptimal. That is directly related to the risk of death during pregnancy. How to judge there is compliance with medication. Seizure diary is of prime importance, obviously, and there are occasions where serum level is mandatory and indicated. And in particular, I will put 2 lines under lamotrigine. So lamotrigine is not only protein bound, but it's also affected by plasma volume and availability during pregnancy. And it's almost always subtherapeutic if you continue on the same dose during pregnancy. It is one of the very few anti-epileptic medication where serum level needs to be checked during pregnancy. Obviously, you're guided by serum level, but you're also guided by increased seizure frequency. Part of the normal care obviously includes folic acid, vitamin D, and so on and so forth. A very important point to remember treating patients with anti-epileptic medication is that we said that there is mental health issues related to the fact that it's a chronic medical problem, but also remember some of the anti-epileptic medication can lead to depression and anxiety and also suicidal ideation. Subsequent visits, you look into seizure frequency, dose adjustment. One of the important things is to involve our anesthetic colleagues to discuss pain relief in pregnancy and pain relief in labor. Just a quick reminder, pethidine can induce seizures, so it's completely contraindicated. Diamorphine is an alternative. Obviously, I tend to advise for early epidural for better pain relief and less stress to reduce the chances of seizure during labor or in the immediate postnatal period. Do I need a delivery plan for everybody? Do I need to induce everybody? The answer is no. Induction of labor is not dictated by epilepsy. It's more or less dictated by obstetric indications. There are very, very, very few cases where seizure control is a reason for delivery. And I hope you never have to have that to make that decision, because obviously you're getting to an area where her risk of death is going higher and higher. Don't forget to raise a neonatal alert and make sure that our neonatal colleagues are aware of the baby, especially if you're talking about polytherapy. This is our normal path for screening in pregnancy, and I just tried to use some arrows to remind you on how many times you need to see patients with epilepsy in pregnancy, how frequent you need to see them. And by the way, this is routine. This is for people who have very good seizure control. The reason why I put these two red arrows is that the chances of cluster seizures is highest in the immediate post-delivery time, and the chances of drug toxicity, if you ended up increasing the dose as for lamotrigine in pregnancy, the chances of toxicity starts from week 2 onwards. This is the time where your neurologist colleague needs to review and you needs to start reducing the dose gradually. Always don't stop medication. If you're thinking of adding medication, it's under the care of a neurologist. If you are thinking of increasing the dose, it's under the care of a neurologist. All these medications come with side effects. Some are mild, some are preferable, as in lamotrigine, for example, which is the widest used. Lamotrigine, for example, is a mood elevator, so they don't end up depressed, they end up actually much more satisfied during pregnancy. But levetiracetam, which is the second safest drug during pregnancy, is associated with possibility of depression and also rarely suicidal thoughts. The blue arrow reminds you of the need of complete transfer of care back to the neurologist. And that's the chance of you, that's the time for you to consider thinking of contraception. Right, so what have we learned from Embrace? We've learned that out of the 19 women who've died, actually 4 are not taking their medication. And I'm sure for you who have looked after ladies with epilepsy, it's not uncommon for women to decide to stop medication. We really need to educate women about the chances of hypoxia on the chance of cerebral palsy as a result of repeat cluster seizures. Lamotrigine is a big culprit because very few actually do serum levels. Very few receive pre-pregnancy counseling, despite us trying very, very hard to invite them to clinics, and lack of specialist review. So escalate, escalate, escalate. Increased seizure frequency is a culprit, always misinterpreted. There is fear of increasing medication. Patients end up with cluster seizures.
Dr. Nida? They got disconnected. شكرا جزيلا دكتور ندى على المحاضرة. يمكن we lost the last maybe couple of slides. I'm not sure what happened.
She said that she is disconnected and she may return back.
Okay, so wait. Okay. Okay, I think it's time to call our next speaker. While waiting for Dr. Nada, maybe she can continue with her presentation after that. It is our pleasure to have Dr. Odey with us. And Dr. Odey Ali, he will talk to us about hypertensive disorders in pregnancy. Dr. Odey Ali, MBCHB, MRCOG, consultant obs-gynae, Royal College tutor, and lead colposcopist. He works at Cambria in the UK. And as I said, he will talk to us about hypertensive disorders in pregnancy. Dr. Odey, once again, thank you for joining us today. And the mic is yours. Thank you.
شكرا جزيلا ومرحبا بكل الطيبين. I would like to share the screen now. Just 1 second. Doesn't work, Dr. Rafid, for some reason. Okay, yes. No. Share screen. Okay.
Okay. Message privately.
So my is the bread and butter of anybody who's specializing in obstetrics. Hypertensive disorders in pregnancy, it's a wide subject. I would like to start with asking the question, what is normal? And normal in science terms is what is statistically normal, which is the curve of normality by Gaussian curve or the normal distribution or bell inverted or bell curve, which is the normal distribution curve. If you have such a curve, you got population within 5% to 95%, and then you label them as normal. So when it comes to blood pressure in the normal population and also in the pregnant population, you got the ideal blood pressure 90/60 to 120/80. So then you can label people as having high blood pressure if they have blood pressure 140/90, and low blood pressure if they have blood pressure less than 90/60. So we need to be aware of something called white coat hypertension. When you measure blood pressure in the stressful environment of the clinic, when people have parked, rushed to the clinic appointment, you do get higher readings. And the way to know about it is to give them blood pressure self-checking machines. You record that, and you find that probably the blood pressure goes down to normal when they go to the normal environment. And the reason I'm saying that, because we need to avoid over-treating blood pressure. We need to be a bit critical, what is the normal value for that person. So to come to the classification of level of severity of high blood pressure, we, with regard to pregnancy, or to normal population as well, mild is 140, the systolic 140 to 149/90 to 99. Moderate is 150 to 159/100 to 109, and severe more than 160/110. So I want to come to this subject, which is ambulatory blood pressure monitoring. If you measure the blood pressure across the day in a normal population or normal number of people, you do get some sort of circadian rhythm where the blood pressure goes down in the evening, it's up when you wake up in the morning. The reason, it does follow the cortisol cycle and also the melatonin hormone. Very important thing we need to notice, the blood pressure is reactive. If I paint my office red, I can increase my blood pressure by 5 millimeter mercury, the systolic, and I can increase the diastolic by 3 millimeter mercury. That's why when you go to Chinese restaurants, they're all painted in red because they want you to eat and go out, so the next customer will come. But it does have an impact, what we go through, the stress, the stress of the day. And again, I want to mention that there is risk of over-treatment. And that's why sometimes if you are not sure, especially if you are treating a non-pregnant person, you're not sure to treat or not to treat, then you give them ambulatory blood pressure machine, send them home, get the recording of 24-hour or a week, then you can come back with some sort of basically number to work with. And this is persistent value, not an occasional one. What happens in pregnancy? There are so many things happening in pregnancy. Because of the progesterone in the pregnancy, there will be vasodilatation. There's also the physiological anemia. And very important, there is the effect of the peripheral vascular resistance will drop by 20%. And later on, from 20 week onward, there will be compression of the IVC. So if you are measuring blood pressure for a pregnant lady lying down, it will be different when she sits up. And these two curves indicate what happens in the systolic in a normal circumstance. And you can see that towards the middle of the pregnancy, there will be a drop in the systolic. And towards the end of the pregnancy, there will be a bit of raise in the systolic. And in the diastolic, there is more exaggerated change. There will be a drop in the middle of the pregnancy. And then towards the last trimester, there will be raise in the values. Now, in coming to the pathology, we have three conditions specific to pregnancy. We have essential or chronic hypertension, and we have gestational hypertension, and we have preeclampsia. So what happens in essential hypertension, you got an exaggeration of the normal values. So you got this curve similar to this curve, but on a higher value, and the same thing with systolic. But what happens with preeclampsia is that you get definitely a trend towards worse values from the middle of the pregnancy onward. If you want to take something from this talk, I would like to share this with you and an image to keep in your mind. And this explains everything about preeclampsia, almost everything. The cardiovascular system is a closed hydraulic system. So the blue is blood. You got force 1, you got force 2, and you got area 1, you got area 2. So in this closed hydraulic system, if you imagine this is the medium-sized arteries, and the vasoconstriction is force 1. So you got smaller area here. So because it's a hydraulic system, this pressure is transmitted to a bigger area, which is the small capillaries and the vessels. And this little pressure here will be transmitted into this big area. And this is the discovery of Pascal. And actually this hydraulic system is used everywhere. It's used in airplanes, it's used in machineries. All you need to do is to press little bit and little force, and it will transmit this force, and you can put a car here. So I want you to just take that concept and think of F1 as a vasoconstriction, and the force 2 is the border between endothelium and epithelium tissue. And you can find these borders everywhere. You can find them in the kidneys, you can find them in the placenta, the retina, the liver, the lungs, and also around the membranes of the red blood cells, and also in the brain. But if you just reflect, where is the biggest surface area to injure? And nothing like the kidney comes number one. And the other thing is the placenta. So out of these two organs, these are the weakest link in the cardiovascular system, and hence the clinical presentation. And the first thing you see in preeclampsia is proteinuria, because the kidney has sustained this mechanical force at the cellular level. So I just come to what is chronic hypertension in pregnancy. you have two situations here. Either you got somebody who's already hypertensive on medications and they got pregnant, or you get somebody who's pregnant and from the start they show high values. In this, the antenatal care is really important. You have to think of, if they come to you before pregnancy, is a golden chance to modify their medications. There are certain medications to stop. AC inhibitors definitely they need to stop, and as well as diuretics. And also the chance to advise about lifestyle changes, like exercise, losing weight. And if they get pregnant, they need to be taken out from the normal population of pregnant ladies, and they require extra monitoring. They have increased risk of preeclampsia. We aim for the blood pressure if it is before the pregnancy, it's normal. We aim for less than, it should be less than 140/90. With regard to the course of pregnancy, the blood pressure does follow the normal trend. It dips in the middle of the pregnancy, and towards the end, it can be exaggerated. The decision for delivery should be not, basically, if the blood pressure is controlled, we aim to have a normal delivery towards the third trimester. We shouldn't aim for an earlier delivery. That is not in the NICE guidelines, which is the guidelines that we're bound by to follow the practice. And these patients, they need to have normal review in 6 weeks. Coming to gestational hypertension, the difference between this and eclampsia and between chronic hypertension is that this is a hypertension that appears at the later part of the pregnancy, but we struggle to find evidence of organ damage. Basically, we struggle to find evidence of endothelial injury. And the risk factor for that is nulliparity, elderly, like age above 40. And if you got multiparity, then the space between two pregnancies more than 7 to 10 years, family history of preeclampsia, twin pregnancy, high body mass index, gestational age at presentation, and previous history of hypertension, pre-existing vascular condition, pre-existing kidney condition. So what do you do with these pregnancies antenatally? You have to give them full attention, like preeclampsia, and the full scrutiny and microscopic management of their pregnancy with full clinical biochemical assessment, and target the blood pressure a little bit higher at 135/85. And you need to monitor blood pressure weekly. And again, I stress this, we need to avoid prematurity. So if you got a lady pregnant who is like a gestational hypertension, I would not induce her at 37 weeks or something like that. I would go, if clinically, if the blood pressure is maintained, I will try to normalize the pregnancy if possible. Postnatally, there may be an observation of persistent high blood pressure. It treats with a bit higher target, 150/100. But again, you need to make sure that by 6 weeks, there is some sort of review, either ideally at the family doctor, to make sure that this is not persistent. Now, coming to the most important thing is preeclampsia. So preeclampsia is blood pressure with organ injury. It's basically a mechanical force that shears the endothelium and causes a multi-system disease. The reason why it happens, in simple terms, you have to understand that the baby is alien, is an antigen to the mom. To allow the pregnancy to carry on, the mom immune system has to surrender and switch off and allow this foreign body to carry on. So you got borders between two countries, the mother and the baby. And sometimes this border is towards the baby, or there's sometimes you get affected growth, or this border is towards the mom, where the mom is affected severely and the baby's fine. So the presentation of preeclampsia is a bit variable. Sometimes you get all the spectrum of high blood pressure with headache and multi-organ damage and stuff, and the baby's fine. And sometimes you get severe growth restriction and the mom's fine. So you have to be clinically aware that sometimes the presentation is variable. Occasionally you get heavily proteinuria, where there's a lot of proteinuria and the blood pressure is normal. But I want to say one thing is that preeclampsia demonstrates one thing about obstetrics is the importance of antenatal care. And if I come back to this, why it happens at the at the implantation level and also at the histological level, you got the spiral arteries where they need to open up into or remodel, let's say, to a low resistance system. And that low resistance system allows the perfusion and the normality of the placental function. For some reason, this remodeling is deficient and defective, and you got high resistance vessels all the way through. So the placental system thinks it's not getting enough and sends the vasoconstrictors to the system to keep the blood pressure higher. And that's what is happening. And a similar mechanism is nephrotic syndrome or nephrotic syndrome. It is almost similar clinically. So what do you do if you have a patient in antenatal care? You have to have risk assessment. It's your golden chance to calculate the risk for the pregnancy and score that pregnancy. It is high risk, it is normal. You need to think of family history. You need to think of the the risk factors for preeclampsia, which is primary parity, twins, obesity, extremes of ages, new partner, also chronic hypertension, antiphospholipid syndrome, renal disease, and molar pregnancy. Now, I would like to share this, can we prevent preeclampsia? I don't think we can reduce the risk, we can modify the disease, we can basically prevent problems, but we cannot 100% prevent it. But can we predict it? Yes, there is like biochemical test to predict it, which is placental insulin growth-like factor. Another thing you can do is also to measure return artery resistance and can correlate with the risk of preeclampsia. But what can we do if we predict PET? The first thing you do is you take this patient from the normal pool of normal pregnancy or midwifery led into a consultant led, and you increase the frequency of observation. It is recommended you think of aspirin, 75, 150, depends on the severity, early on from 12 weeks. And also there is evidence for vitamin D supplements. That is strong evidence that this reduces the risk. Doesn't prevent it, but it does reduce risk. There's no evidence for other things like fish oil or cod liver oil or other stuff. It is some people think that this is preventing problems, but the only evidence is for aspirin and vitamin D. And also the most valuable test is blood pressure and the urine, and you adjust the frequency according to the severity, to the clinical history. Also, you check ultrasound, you put an eye on the baby's well-being by regular scanning. So how do you diagnose it? You got red flags, you got the blood pressure, which is value number to work with, to record, is whenever you got persistent value more than 140/90. The other thing I would like to say and share with you from my clinical experience is sometimes I do get worried about preeclampsia, even with a normal blood pressure. So if somebody has a little bit elevated blood pressure, but you got headache, again, you need to think and you put your clinical experience here. And the symptoms reflect the effect of the increased pressure in this hydraulic system. So you get the headache is one of them, visual disturbance. You need to think of abdominal pain, and all these things reflect the organs they are affected by the blood pressure. One thing I would say is to check for reflexes. This is where you put a hammer in your hand and check the reflexes and see if they are brisk or not. You need to be aware that some people are anxious. They do get increased reflexes. And also you check the clonus. If you got the skill to look at the retina, it's great, because in acute evolving situation, you do get some changes in the retina. And I don't think everybody's skilled in that, but it is one of those things. Very important, is one of those rare occasions as an obstetrician, you put the stethoscope on your chest and listen to the chest. The reason is that in severe cases, when there is endothelial injury and there's a risk that the patient will not tolerate fluids, and you can get loaded lungs with the fluid, and hence the oxygen saturation is really important. So the next thing, if you you suspect it, you do blood test, and you aim to check the maternal well-being through the biochemistry. You check the renal function. The increased basically cardiac output in pregnancy make the pregnant lady normally filter creatinine. So you adjust the creatinine from 120 to 70. So 70 is upper limit of the normal for kidney function. Uric acid, usually it's rough indicator, it's not the discriminator, but it does correspond to the pregnancy weeks. And also need to keep an eye on the liver function test, and very importantly, urine. Now we are moving to checking the PCR. More than 30 means that there is definitely leakage of protein in the urine, which is abnormal. And hematology, we check the hemoglobin, and we check the platelets, and we check the coagulation. It's exceptionally important to compare this numbers in front of you with the previous number, even with the previous number, and to see a subtle trend. Sometimes you see platelets of 180, 160 coming to 140. That change in itself, it's significant. Once you check the mom's well-being, you need to check fetal well-being, and you start with clinical fetal movements, clinical assessment to measure the fundal height. Also, you check the CTG, and also you got the excellent tool of the ultrasound. One of the things that you measure is the growth, the Dopplers, and very important is the Laker volume. This is one of the indicators that baby is struggling. So how do you come to management? I put my clinical input here, and also you can also check the guidelines, but let's consider this talk as tips and tricks. You put maternal well-being first. You need to assess the rate of deterioration or rate or worsening of the condition. Sometimes the rate is slow, so you get a chance to assess, manage on the community. And sometimes the rate is acute, means that you got an evolving situation. The blood pressure is high, it's too high. I just give you an example. One time I was a junior training in Portsmouth in the clinic, in the peripheral clinic, and I checked a lady, her blood pressure was 150 over 100. And I said to her, you need to come to hospital. And she said to me, can I go home first? I said, okay, go and get your bag and then go to the hospital. Next day, the clinical director for the hospital, the labor ward called me, say, excuse me, you had a lady in front of you in the clinic. You need to admit her right now. If she doesn't have a car, you get an ambulance to bring her to the hospital. And he was right, and I reflected on that. So it's very important to stabilize the blood pressure. This number in front of you to adjust to normal. You got many things to do. Our first line is labetalol, which is a combination alpha blocker, beta blocker, 200 milligram. It doesn't work immediately. You need to be patient. Basically, give it 20 minutes. You can repeat the dose, increase the dose. Also, you got the nifedipine. I want to be clear here. Nifedipine, it's really important not to crush it under the tongue. Sudden fluctuations in the blood pressure is also dangerous. Sometimes slow release work for you as well. And then methaldopa. Methaldopa is out of fashion. It's centrally acting high blood pressure, antihypertensive. It does cause depression, and try to avoid going through that. The one thing about labetalol, if somebody is asthmatic, then if severely asthmatic, maybe in contraindication. One thing about the blood pressure, you got two values, the systolic and the diastolic. The systolic kills the mom. The diastolic kills the baby. So both values need to be within range. It's very important to avoid, if the patient is admitted acutely, it's important to avoid fluid overload because the patient is actually intravascularly contracted. Then you force fluid, basically you're going to increase the mechanical injury to the endothelium. Then after that, you need to think of the delivery time. If you have a patient before 34 weeks and she's giving you time, the acuteness of the case is not that rushed, then you have time for surveillance and you stretch the pregnancy until 34 weeks. Between 34 weeks, 36 weeks, surveillance if safe. Steroids has a role. By the way, steroids do normalize some numbers of the biochemistry, hematology, but this is spurious. After 37 weeks, if you got somebody who's on medication, high blood pressure, you need to think of delivery. And the mode of delivery depends on many things, previous past history, and also the acuteness of the condition. If the patient is really unwell, requiring IV medication to lower the blood pressure, you need to think of magnesium sulfate to protect the patient and prevent fits, and admit to labor ward, stabilize. In these situations, if you are inducing, then encourage epidural. Epidural is not a treatment; it is an asset. So, but it does help if you are interventional, you want to do instrumental delivery, cesarean section. It does help. One thing about epidural and spinal in these cases, if they have been on a lot of medications, nifedipine, hydralazine, and you put epidural, I've seen it myself, the blood pressure just sometimes go down very fast. So it is important to stress that the management of preeclampsia in these conditions is multifaceted, multidisciplinary. The anesthetist is your friend, and also you need to care for this patient in high dependency unit in the labor ward if possible. So if you deliver the patient, this is not the end of the story. Sometimes things do get worse after delivery. You have to have one-to-one care. You have to have like a close observation, and need to be aware that there's a variant of the preeclampsia called HELP, which is hemolysis, elevated platelets, elevated liver function tests, and platelets, and low platelets. Basically, it's variant of preeclampsia. Sometimes, majority of cases are postnatal, not antenatal. And the main effect of the disease is on the red blood cells and gives you hematuria. It is one of those conditions that you need very high input from the intensivist, anesthetic, hematologist. You have to have very close eye on the fluids in and out, and you need to normalize blood pressure all the way through, repeat bloods frequently. And very important not to forget about thromboprophylaxis. Those patients are very prone to thrombosis. And then if you normalize them, and then a majority of them, they turn corners before discharge, it's a chance for you to improve their health for the future by postnatal counseling. It's a good chance for you to discuss contraception, avoid the combined pill. Need to encourage them to check their blood pressure in 6 weeks and yearly, and also need to explain the risk of recurrence. And all those people who have preeclampsia, if they have severe ones, they have increased risk of cardiovascular disease in the future. I would like to thank you. I kept it simple. I want to take this opportunity to say preeclampsia kills women. I've seen it, and it still kills women. This is my statement. I would say if you want to take this as an indicator of a good unit, then diagnosis, management of preeclampsia reflects the excellence of antenatal care and also the quality of intrapartum care. And I'm happy to be challenged on that by my colleagues, but my belief. Thank you very much.
Thank you, Dr. O'Day. Very interesting subject and presentation. Thank you very much indeed. I'm not sure if Dr. Nada is still with us to complete her presentation, or we go to the questions and answers now. Dr.
I'm back. Thank you.
All right. Okay. So if Dr. O'Day can Yeah, okay. Now, do you want to share the presentation? Let's see what you go through the rest of it, please.
Shall I stop the share? Okay. So.
Right. I hope you can
Thank you.
hear me.
Yes, yes, we can. Thank you.
Okay, thank you very much. My sincere apologies. It's a bit of an connection problem, electricity problem, as I am now in Baghdad. Right, so going back to where we were, just a quick reminder, we were talking about why we misdiagnose or why we miss risk assessment or underestimate the effect of epilepsy on these patients. I'm just going to try to go back to slide presentation. Apologies. Right. Okay. Right, I probably will stick to where we are just for the sake of time. Moving on. So, as you're aware, we're talking about cases based in the UK, and we're trying to learn from other experiences. Essentially, the recommendation from the Embrace report, that's recent one, is to develop clear standard of care for joint maternity and neurology service. I would highlight and put 3 lines under neurology services. Please remember that neurology services doesn't mean always having a neurologist with you, because it's not a facility that's always available. Essentially, you expect it to be in tertiary centers and referral centers. And an alternative should be either a community-based epilepsy service, as in the UK here, we've got general practitioners with special interests in epilepsy, or trained epilepsy nurse who can attend and communicate with your patient and be the first contact for patients struggling with seizure control. Obviously, these auxiliary services and additional services are directly linked with neurologists to support any significant change in patients' behavior. Obviously, again, if seizure control becomes a sudden problem, then early recognition of the problem, early escalation, early involvement of the neurologist may reduce the chances of sudden death during pregnancy. And as you can see on this slide, I chose to put a red line under prompt postnatal review to ensure anti-epileptic drugs are reviewed. So essentially, if you remember earlier from my talk, we presented the Empire study where there was a suggestion of not using levels of anti-epileptic medication during pregnancy as regular practice, but we also touched on the chances of lamotrigine being subtherapeutic and the need of using levels for lamotrigine. Essentially, based on my experience in the last 7 years looking after ladies with epilepsy, almost always, if you send a lamotrigine level during pregnancy, it is subtherapeutic. With some patients, we choose to just repeat the level if their seizure control is okay, but with the majority of cases, you end up with a much higher level of lamotrigine, a much higher dose of lamotrigine. Essentially, if you remember pathophysiology and what happens in the postnatal period, these medication, these doses which were appropriate for use during pregnancy, will become toxic in the postnatal period as the plasma volume reduces and the glomerular filtration rate goes back to normal. So essentially, and if you remember the graph that I showed earlier, between week 1 and week 2, it is essential for a neurologist input to start a plan of gradual reduction in anti-epileptic medication to avoid toxicity in the postnatal period. Right. As we said, there is an alternative to a neurology opinion, You've got epilepsy nurse specialists, you've got a specialist midwife, obstetric physicians like myself. But again, I still think that they are too complex for us obstetricians with special interest or special training to make these decisions, and neurology input is essential. What about anti-epileptic drug management? I think I've touched on this during my presentation. Several had low levels. Most of the postmortem cases had low levels. There is ongoing reluctance of increased dose because of concerns regarding fetal risks. Again, educate, educate, educate. Hypoxia can kill mothers and essentially can kill fetuses and can result in cerebral palsy in the fetus. I'm just going to touch on this because I think it's extremely important. Some patients have learning difficulties as a coexisting problem with epilepsy, and some patients develop learning difficulty or slow learning or slow response as a result of repeat cluster seizures. These are very difficult patients to manage. They need intense care, they need one-to-one care, and they need special raised risk, if you like. And unfortunately, some of these patients ended up drowning in bath because of lack of advice on safe care during pregnancy and outside pregnancy. I am going to finish my talk with saying Embrace has summarized the need to educate about SUDIP, alternative to neurology opinion, and making use of nurse specialists. Also, lowest, and as you say, we say lowest effective dose of anti-epileptic, and they highlighted the importance of witnessing nocturnal seizures. I made a take-home message, and I think I agree with many of my colleagues. Think mother, mother, and mother. A well mother means a well baby. Do not stop medication. We spoke about anoxia and hypoxia. Remember the importance of seizure control as your first priority. Remember the importance of a neurologist opinion, the need for escalation. The time is very constrained, so I didn't have a chance to talk about differential diagnosis, but somebody with cluster seizures who have had very few seizures during pregnancy, think of a coexisting pathology and do provide them with imaging. Remember, pregnancy itself should not change the course of investigation and diagnosis. Remember postnatal medication review. Remember contraception. And most importantly, remember, patients with epilepsy are very complex. They need personalized, individualized care plan. Guidelines are to guide, and evidence needs to be interpreted in the context of risk categorization for these patients. Thank you very much, and I'll defer the questions to the panel. Thank you. And apologies for the right-through interruption. Thanks.
Okay, thank you, Dr. Nada. I'm very glad that you managed to come back again and to complete your presentation. Very good presentation. And I think I agree with all the speakers. They all talk about early intervention, early care of the mother, and early detection of any issues or any illnesses or any medical conditions. I think it's time now for the questions. And I have a good list of questions, and I'll ask all the speakers to join here to answer the questions they feel is related to them. I will start first from a question from Dr. Talal. Is the physiological mechanism of headache known yet or not? I think Mohammed can answer that question.
Yeah, it's basically what we know is a primary headache that is has no pathology behind, and the example of that is the one with tension headache, in which the reason is the muscles of the scalp get contractions and causing the headache. Now, migraine is another primary cause of headache. It's not known what is the reason. There is a possibility of vasoconstriction. These are the physiology of the primary headache. The secondary headache, there is a pathology behind it, either a bleeding or a thrombosis or a tumor. So this is my answer.
Thank you, Dr. Mohammed. I got a question from Dr. Yusra Tahir Jerjis. Is serum lactate measurement available in maternity hospitals in Iraq? I think the Dr. Taghreed Hatem, and also Taghreed Haidari. I don't know anyone from Iraq can answer these questions. Do we have lactate measurement in the maternity hospitals in Iraq? Noor, are they on mute maybe? No.
السلام عليكم.
عليكم السلام.
هلا دكتور محمد دكتور رافد لو عيني. بالنسبه للاكتيت موجود. بالنسبه للي يسال اللاكتيت هو من ضمن الاي بي جي من ضمن البلاد جاز اناليسيس.
نعم صحيح. Yes, it is within the arterial blood gas machine. You can check the lactate. Also, I would like to share something that from my own experience. I started our area in the primary care for the urgent care services in 2017. What I did, I searched about, is there any easy way to measure lactate? And what I found there's a lactate machine. It comes like the same size of the glucometer, the small glucometer. And it is not expensive. It is about 300, less than 300 pounds. And you can do the test. It is very useful. So when we see patient in primary care and we suspect sepsis, it's a needle prick test. Check the lactate above 2, then you can refer to the secondary care, or of course, before that, we start antibiotics for them as injection antibiotics, call the ambulance, and take them to the A&E. As I said earlier, every 1 hour delay in treating sepsis or giving the antibiotics will reduce the chance of survival by 7%. Every 1 hour delay. So it is really, really important is to give the antibiotics as soon as you can, as soon as possible. Thank you. There's a question from Dr. Zuhair Kamal. What is the prognosis of a pregnant woman in sepsis, and did the steroids reduce the mortality rate?
Okay, I will answer. The prognosis of, do you hear me, Doctor?
Yes, we can hear you very well.
Yeah. In the beginning of the lecture, I said it is a very high mortality rate. When diagnosed a pregnant woman with SIRV or severe sepsis, the mortality rate reach 50%, which means she has chance of 50% to die. And that's why it is called the golden hours. What the mean of golden hours? If we miss to treat the lady in this 1 hour, we end with irreversible shock.
Yes.
About the steroid, it is not recommended to use in a pregnancy. It may be mask the feature, but we can use it only to promote long maturity of the baby.
Yeah, with cautions, of course, regarding sepsis, because can make things worse. Okay, I got more questions coming. Just give me 1 minute to arrange myself for that. And now I got a question.
Sorry, can I have some comments on that?
Again, Dr. Zuhair, sorry.
I'm Dr. Taghreed. Can I have a comment on some of these questions? Regarding the lactate dehydrogenase, I'm not sure if Dr. Taghreed is talking about a tertiary center. Otherwise, it's not available in all hospitals. Is it available in medical city only? I'm not sure it's available in the secondary hospital or other tertiary center. This is one. Regarding any data for that in Iraq, we don't have, unfortunately, data for a type of microorganism which causes sepsis in women in Iraq.
Okay, thank you. I think we can talk, maybe we can help each other regarding what we use now. I mean, I can help you with, I can send you the the name and the of the lactate monitor we use in the primary care, which is very easy to use. It's like a glucose, very cheap.
One comment, Dr. Rafid, one comment. Serum lactate is it is available and very easy. As you said, it is only a small machine. It is available in the medical city, in the IC unit, in the emergency, and even in the HDU in our unit. Maybe no one see it, but it is available. It is a routine investigation in the ABG analysis. And you can find it wherever there is an ICU unit.
Yes, but that means tertiary unit maybe, or maybe maternity hospitals where there are no ICU. Again, I mean, I always, when I do the training for the trainees, I tell them that it is the clinical picture is important. So before we reach to go for investigation, again, I mean, check the blood pressure, check the pulse, check the temperature, and just by that, and also how the patient look. In your lecture, Dr. Tagreed, clinical picture is very important also to maybe to figure out, I mean, the condition and to give the antibiotics earlier, then you can move them to the ICU or HDU. I have a long list of questions, so excuse me if I have to go quickly with them. I think Dr. Tagreed Haider answered this question regarding what are the most common microorganisms which causes sepsis in pregnancy in Iraq. Is that Dr. Tagreed said we don't have studies about that?
Yes, yes, unfortunately, we don't have exact data for that.
Okay. Then we go to the next question is from Dr. Afra Amin. The role of vitamin D in PET. Is that true, Uday?
Yes, there is epidemiological studies showing that people taking vitamin D, they have lesser severe presentations of preeclampsia. So 1/3 of people living in the UK are vitamin D deficient. I don't know the exact mechanism, how does it improve things, but vitamin D has proved its benefits there. Yeah.
Okay, so there's a benefit, which is good. Thank you. But to be honest, the vitamin D now, as they talk about so many benefits of it, I don't know what is the facts, what are the myth of it, but definitely there's a role for it. Thank you. If I go to next question, and this is from, there's no name here. What are the indications of aspirin in obese pregnant women? This is for Dr. Haidari.
Yes, as we said that pregnant women, obese pregnant women, if the body mass index is more than 30, it's contribute to the moderate risk for the woman. So multiple moderate risk will increase the risk of having hypertension during pregnancy, and high body mass index is one of the moderate risk for that. So we prescribe aspirin in the second trimester if she has more than one moderate risk for having hypertension. And one of them, as I said, is obesity.
Okay, what is the dose, Dr. Tagreed? Is it 75 mg or?
It is the same. It is the same 75 or 81 milligram.
Okay, thank you.
Yeah.
Okay.
Yeah, welcome.
Dr. Ala Hamid asked regarding the PCR in maternal assessment of hypertension. Can we use PCR, Dr. O'Day?
Yes, the reason we use PCR because there's so much uncertainty when you test the urine for proteinuria. In the old days, you have to have, even in the old days, you used to boil the urine or boric acid, and then you see how cloudy it is. That was the old way of doing it, but then it came into a simplified way of putting the dipstick, and dipstick is a reagent. It gives you 1+, 2+, 3+. Now, if you check the urine 1+, then you are not sure it is secretions, it's contamination. If you check it in the morning, also may not be representative. How do you solve the problem to get a number, qualitative number that gives you that this is proteinuria and this is abnormal? Then you do the PCR. So yes, that's the way about knowing that there is protein leak, which is abnormal, reflecting endothelial damage.
Very good. Thank you, Dr. Uday. Another question for you as well from Dr. Nadia Barakat. Can we give low heparin to patients with hypertension pregnancy?
There's no indication for, there's no evidence, let's say, of giving heparin. The indication for heparin is that careful risk assessment of the thromboembolic risk, like previous event, family history, a non-genetic disorder. But there is, as high blood pressure, there's no indication. You cause more problems, actually.
Thank you, Dr. Uday. A question from Dr. Yusra Tahir Jaljiz. Can we do ECG in pregnancy?
Sorry, I'm going to answer this.
Physiological
You're
changes.
saying EEG.
Oh, sorry, EEG, sorry. Sorry, my apologies.
Yeah.
I haven't thought about EEG.
Yes, EEG can be done during pregnancy, and the interpretation is exactly the same. So there is no variation.
Okay. And,
So,
as you are with
yeah,
us,
the answer is there is no variation.
no variation as with physiological variation. You mean?
ممكن نستعمله. Oh, just a quick update. بالنسبة للدose of aspirin in prevention of hypertension. We've got recent evidence to suggest that we actually need a higher dose. Well, so we moved on to give 150 milligrams as opposed to 75 milligrams or 80 milligrams. I don't know about the practice in Iraq, but we definitely have moved to the higher dose.
Okay.
So the chances of prediction or reduction of risk of recurrence of preeclampsia is 1 in 25 with 75. And I think it is dropped to about 1 in 13 with 150. So we've moved to a higher dose.
Okay, that's very good to know. Thank you.
Okay.
Dr. Nizar, as you are still with us, this is a question from Humam Khalid Muhammad. What is the best, safe, and effective anti-epileptic drug for pregnant women? Epileptic pregnant women.
The best in terms of safety profile for teratogenicity is primarily levetiracetam and also lamotrigine. Unfortunately, there are a few patients whom we don't achieve seizure control with these two medications. And we end up either with polytherapy or with those with a slightly more teratogenic effect. But primarily is lamotrigine because it's also a mood regulator and mood elevator, and levetiracetam, which is known as Capra.
Yeah, thank you. A question to Dr. Muhammad Aziz from Humam Khalid Muhammad. Dr. Humam, he said, what are the medications for pregnant ladies with migraine? Are they the same for non-pregnant?
Use the triptans and simple analgesic in pregnancy. So these are the medications. For prophylaxis, propranolol, and sorry, the propranolol, the most commonly used.
Okay.
For prophylaxis. Yeah.
Okay. That's all the questions I received. I just would like to ask one question to our colleague from Iraq regarding training for sepsis. I mean, training the new doctors, the doctors in training. I mean, also the senior doctors as well. I mean, we run a training in our organization. I run training for sepsis. I lead on that twice a year. And every doctor should have at least once a year training in sepsis. They can do it online, but we encourage them also to attend one, which is like physical one-to-one. Now we do it, of course, virtually. I mean, can one of the colleagues from Iraq, I mean, tell me about training in sepsis in Iraq, how we are with that?
مرحبا دكتور رافد.
مرحبا دكتورة.
بالنسبة للسبسز in general يعني هي ماكو دورة معينة مثلا حول موضوع الخمج أو السبسز، لكنه أكو محاضرات بالنسبة للباطنية يعني تقريبا في كل موسم عندهم up to date how to diagnose and what sort of antibiotic and what the microorganism. بالنسبة لنا بالنسائية والتوليد يعني صراحة احنا عندنا شحة في المعلومات حول المايكرو اورجانيزم، وايضا عندنا شحة في معرفة علامات و sign and symptoms of sepsis in pregnancy. كثير حالات ما تشخص حتى وإن كان consultant in obstetric and gynecology يعني أكثر الحالات they draw no attention ما يخلون ببالهم السبسز because of the mask of the features. يعني كذا مرة تحول إلى مدينة الطب، يعني آخر مريضة حولت كاتبين بالإحالة بالضبط إنه هي drug allergy because of skin rash، بينما هو السكين راش مالتها كان بسبب السبسس.
Yes, I think that, yeah, I think that, so it is really, we need to increase the awareness about sepsis as we do here. I mean, everywhere you can see leaflet about sepsis. You go on your desktop, you can see the screensaver is about sepsis. In the hospitals, in the offices, there's always something there to remind you about sepsis, remind the clinicians and non-clinicians as well about sepsis. So campaign maybe about that in Iraq. And again, I mean, I'm surprised that in Iraq, I mean, there are so many people, they go for simple cold and they get ceftriaxone or something like that, injections. And then when it comes to sepsis, they don't give them many antibiotics, which is, they refer them thinking it is allergic reaction.
And there is misuse of antibiotic. There is misuse, a lot of misuse, and a lot of drug resistance.
Yeah, and that doesn't help us for that add to the problem.
And we are going to put a protocol in our department. We do a protocol for placenta acreta because we have 2 years no maternal death with the placenta acreta, and then in the 2019 we have 3 deaths with the placenta acreta, and we put a protocol, local protocol for medical city, and الحمد لله والشكر يعني هذه السنة 2020 ما صار عندنا أي وفيات أمهات بالنسبة للمشاكل المشيمة، وإن شاء الله راح نبدي نسوي بروتوكول بالنسبة للخمج يعني بروتوكول for sepsis إن شاء الله تعالى.
بارك الله بكم. And at the end of this meeting, I'd like to thank you all the speakers for your time. So this question.
I think Rafid, there is a تغريد الحيدر دكتورة تغريد وضعت comment. How many subcapsular subcapsular hepatic hemorrhage or hematoma? And they have 2 cases in 2019 in Iraq. So basically, it's very rare to have it here in the UK because of the antenatal and intrapartum care is a bit different. So this may be the main reason.
Yes, unfortunately, they were undiagnosed and they have rupture hematoma, diagnosed after rupture of hematoma, and both of them they end with the maternal death. One of them on the second day, and one of them after 15 days in the ICU.
It's catastrophe. It's definitely
yes, it is catastrophic. Yes.
Thank you, Dr. Tagreed.
Thank you.
Okay, one of our gentlemen raised his hand.
Hi, good evening.
Good evening. Could you introduce yourself, please? There's no name on the screen.
دكتور رافد.
أهلا وسهلا.
أنا دكتور قيدار الشلبي اختصاصي في الطب الفيزيائي والتأهيل
دكتور
الطبي.
قيدار، نعم أعرفك بس الصورة ما واضحة جدا. أهلا وسهلا بك.
قاعد بالحديقة الآن.
اهلا وسهلا دكتور قيدار.
الله يخليك ويحفظكم. أنا عاشت ايديكم على هالويبنار هذا، بس أنا عندي حقيقة سؤال اللي أنا أعاني منه بالسبيشالتي مالتي. A lot of pregnant women after delivery, they come to me with sacroiliac pain and pelvic pain, which is due to increase in the production of relaxing hormone in the last trimester. And these people, they might continue suffering from this pain because of the widening of the sacroiliac joint and the pubic symphysis. Is there anything apart from and physiotherapy, like any medicine to get this relaxing hormone back to the normal level or not? And thank you very much.
I don't think so, Dr. Qaidar. It is just the physiotherapy which we use and the analgesia, especially for symphysis pubis dysfunction, which is related to the hormones of pregnancy, making the joints more relaxed and stretching of ligaments. I'm not sure if they or any of my colleagues have any comments.
Thank you very much. Thank you. But just to get sure if there is anything that we can add to these people, because sometimes they might continue suffering from that for a lot of weeks or months.
Yes.
Usually it takes weeks to resolve, Dr. Qaidar. Yeah, that's right. Physiotherapy is the most important in the pathway of treatment.
Yes, I used to give them corset at least to help them support the pelvis back to normal so that they get, again, the sacroiliac joint in a place, because they feel as if they are in two pieces, the whole upper part of the body is
right.
a little bit, making a problem to them in walking, in like activities of daily living, etc.
Yeah.
You're absolutely right. It's just sometimes it takes few weeks to resolve.
So nothing apart from only physiotherapy and corset, right?
As far as I know, there's nothing else.
Okay, thank you very much and very nice
Thank you,
to meet you.
Okay,
and
thank you قيدار على المداخلة. شكرا جزيلا.
Thank you.
I just want to remind all our colleagues who join us today, please, there is a link for a Google form where you can do it. And also you can fill the form with your name and email so you can send you the certificate. And the certificate will come fully with the CPD, but there's a box in the middle where you write your name, and it is a Word document, so it's easy to write your name electronically. Once again, I'd like to thank our speakers and very much for the highly and very high standard presentations. Very nice subject, very good subject, and useful for all of us. Thank you very much indeed. I think we will meet you soon, hopefully in a week or two, regarding the mental health seminar. Also, we are planning to do some more medical education as part of the program for UIMA for this year. One thing I would like to advise my colleagues in Iraq and also their families, please be careful. I mean, we are worried about second wave. They might come to Iraq at any time. I mean, I hope it is not, but please, I mean, take all the precautions just in case it is coming. شكرا جزيلا لكم، أتمنى لكم الصحة والعافية وتصبحون على خير. شكرا جزيلا.
شكرا جزيلا للجميع. شكرا جزيلا. تصبحون على خير.
تصبحون على خير.
شكرا جزيلا. تصبحون على خير.